Hello, this is Dr. Riley, family physician in St. George, Utah. Today I want to talk about two different principles. One is government intrusion into medicine, and number two is the opioid crisis. So, as most people have seen in the media, this has now become a national issue. Well, this was an issue that was national long before it became present in the media. Unfortunately, we're a little behind the curve in trying to take care of this. One of the reasons why I wanted to bring this up was the principle of government intrusion. And having recently listened to one of the experts in our state on opioid reduction for our area, there were a few principles that kind of jumped out at me that I want to talk about. The first one is the incidence of opioid use increased significantly after JCHO, a federal organization that regulates practices in hospitals and in clinics and making sure that we're following certain standards, mandated that pain was the fifth vital sign and that this was something that needed to be monitored at every office visit, at every stay in the hospital, and that we should be doing more and being more aggressive in managing pain. Well, unfortunately, I really believe that that was one of the turning points in the opioid crisis. And you can see the data from the Utah State Department of Health website will show that the incidence of opioid use did increase directly after 1999. That's one of the events that I think significantly contributed to this crisis. If you look at the data for the state of Utah, every month, 24 individuals die from opioid overdose deaths. From 2013 to 2015, Utah was ranked the 7th highest in the nation for drug overdose deaths, directly associated with opioids. Research is now being done which shows that chronic use of opioids may not even make a significant difference in healthcare. That even though we might be able to mask somebody's pain, the whole point of using opioids in the first place is to improve somebody's quality of life, and that means including their functionality. And the data is now starting to show that that may not be the case, that we may not be increasing someone's functionality or their quality of life or helping their chronic medical conditions overall. In fact, we might be making it worse by giving them medication that then compounds other medical problems by the drug side effects that come, such as chronic constipation and bowel problems, sedation, and obviously death being a big issue that comes along with that. Most patients fail to recognize when they have an opioid addiction or dependency problem. I see this frequently in my office, patients in denial about being physically addicted to narcotics and that there might be a problem of impairment. If you have been pulled over, or if you have a family member that is concerned because you have a hard time staying awake and talking to them, or you've had an increase in falls in your home, the pain medications are probably a problem, and that needs to be addressed. But more than just the pain medications, it might be polypharmacy. It might be that there are multiple medications that you're on that might be contributing to the problem, including things such as Lyrica, gabapentin, or Neurontin, benzodiazepines, which are sedatives like Xanax and Ativan and Valium. So if you're on these medications, you need to really be aware that perhaps you are more impaired than you think you are. Again, people don't intend to die from opioid or combination medication use, but it happens because they are not aware of how much they're being impacted. When I see these patients in my office, they are usually unwilling to decrease the dosage of their medication or perhaps even stop medication, and they're oftentimes not willing to have the conversation about what's going on. They are adamant that they cannot be in pain, which, yes, there have been people that have taken their life because of being in pain so much, but the truth is, outside of suicide, people don't die from being in pain. However, unintentional deaths from opioid overdose do happen. And the other thing is a cultural phenomenon. We are a McDonald's society where we want immediate effects and immediate results. And so if we take a pill and we don't get that immediate effect or result, we take another one. And next thing you know, you are overly medicated and sedated and at risk for death. The only people in this life who are pain-free are dead. pretty much anybody can get up, and during the course of a day, you're going to experience pain if you have a body. That is a given. So recognizing that that is part of life and using other modalities to treat that, such as wellness and physical exercise, and stopping with our poor diets, which trigger inflammation in the body, is a great place. But there are other things that we can do as well. Most people never start in life wanting to be a heroin addict, but most people who have a heroin addiction usually started from a narcotic prescription medication. And more frequently, oftentimes, it may not even have been their own. They might have been giving medication from somebody else. And next thing you know, as time goes on, because of their increased tendency for addiction, they may be dependent on heroin that they never would have imagined in their life that they would have had a problem with. And that brings up another point, that as we continue to work on this opioid crisis, those people who truly have that physical addiction tendency, they will transition from opioids to heroin, and we are seeing heroin deaths on the rise because of this as well. So we need to deal with this crisis with the opioids, but also the heroin problem that comes because of it. One of the major healthcare systems in our state is Intermountain Healthcare, and they are pushing to try to encourage their providers to have a 40% reduction in opioids that are available in the community and in use. And where does this percentage come from? It comes from the data that shows of a prescription that is given to a patient for a medical problem, say for example surgery. If you look at the number of pills that are actually used for that postoperative condition versus those that are remaining left over from the total prescription, that usually comes up to about 40% of the prescription. And that means that 40% that is left is usually sitting in somebody's cabinet at home, saving it for a later day. That means that's a potential for misuse by their children, by family and friends, being stolen from the home and ending up on the streets. That's a problem. That's a potential risk for someone else. So we encourage you, if you have prescriptions left over, please don't save them in your home. Get them to a local police station where they can be dispensed up with a local drug drop box, and not put that at a risk factor in your home. And providers are being encouraged to write 40% less on their prescriptions than they normally would have. If a patient truly needs narcotics for a reason, we can always refill the prescription if we have to, given a medical indication. But if we can just across the board start reducing, one, asking for prescriptions, number two, the volume that is given when a patient is needing a prescription, we can hopefully have a reduction in this crisis overall. The top 3 drugs that are associated with opioid overdose are things that you probably have used: oxycodone, which is found in Percocet, methadone, and hydrocodone, which is found in Norco and Lortab. These are things that are probably in your cabinet at home or that you have previously had experience with. These are not abnormal or extreme circumstances of narcotics that most people have a tendency to think of, mostly because this is what's widely available, and that's what people are overdosing on. The next thing is, maybe you need to have some Narcan at home. If you have a loved one who is on chronic pain medication or has an addictive tendency, or there's concerns about them being impaired, Narcan does save lives. I know this is a controversial issue about whether or not to have it available, but I have seen firsthand, as we have increased Narcan prevalence in the community to first responders, such as police officers and EMS, that people's lives have been saved by getting them immediate reversal of the narcotics in their system by the administration of Narcan. So if you have someone in your home who is on an opioid prescription, perhaps this might be something that you need to educate yourself on about the signs of potential overdose, and have a Narcan prescription available to be administered to them in case of an emergency. Now, the government intrusion part. In spite of this now being recognized as a national concern, and in spite of recognizing that most people become addicted to pain medication because of having been given a prescription legitimately by the provider, JCAHO still has not removed the requirement for monitoring pain as the 5th vital sign. As long as we continue to focus on this as an utmost priority, this is going to continue to be a problem. And the problem is that in hospital systems, monetary reimbursement is directly tied to patient satisfaction, and one of those questions being, was your pain well managed? You can see the problem here. So I challenge those of you who are willing to take the time to write a letter make a concern. You can write to a congressman or a senator. You can write directly to Centers for Medicaid and Medicare Services that you have concerns about this condition going on, where we are pushing to constantly monitor pain, push pain. Not that we shouldn't be monitoring it, but can we find a healthy balance here and get government intrusion out of the equation so that we can work on the problem ourselves as a medical community with the support of you, our patients. Again, this is Dr. Radley, a family physician in St. George, Utah, and until next time, Pura Vida.